So what I believe might be the last presentation of the conference, thankfully. So we're going to be talking about this case series we've been able to do on IV ketamine for adolescent depression. And we're actually really proud of this one. Similar framework that you all have seen, talk about the background, go into the methods, talk about what we saw, and then kind of where things can go from here. So you have heard about this kind of three-pronged framework about evidence-based medicine, patient-centered practices, and partner collaboration. We add a layer for adolescents in that, given the lower volume of data, our practice has been really strict that we will only treat individuals between ages 14 to 18. You'll see why in the trials in a moment. That those individuals have a higher threshold to participate in care than our adult patients. They must have a pediatric psychiatrist as part of their care team, or an adolescent or pediatric psychiatrist. There's obviously a lot of work with parents when it comes to treating somebody under the age of 18. And unlike adults, these individuals actually do require a chaperone to leave the office, so having somebody there to escort them home. When we first started looking into potentially doing this, because we were being contacted by parents, I was actually pretty impressed by the amount of information that had already been published in this. So these are all years like 2021 to 2024, but we have a decent amount of data on adolescents. These trials restricted it usually to the age of 14. I think there's one in here that has a 13-year-old. And as a very high-level takeaway, saw roughly the same outcomes that adults were seeing in much, much smaller sample sizes as we were going forward through this. Because of that research, I don't know if Carlene is still here because she was involved in this, but there actually are official statements around from the American Academy of Child and Adolescent Psychiatry. These were put out in April of 2 years ago now. And they were talking about in these emerging treatments for mental health, ketamine is an option for adolescents, particularly those who've had challenge managing their symptoms to date. They talk a lot about a deeply informed risk-benefit conversation, both with the family, the patient, and their team, as well as ensuring that this is not done in a silo, as can sometimes be the case with adult care. For us, we go real deep into this. So this is one of the cases where basically every adolescent I'm involved with as the medical director for the practice, we have an extra set of informed consent conversations with these individuals. We inform consent the parents. We also inform consent the adolescent. And we make sure to really highlight the fact that, unlike adults, there's not nearly as much data, that the data that is there seems that we have rough outcome equivalence, that there might be a slightly lower rate of response, again, from those studies that were just shown on the screen, but that overall we think it's a reasonable thing to try. Because we've been now doing this for a couple of years, we were able to kind of put together a case series here. So we looked back at charts from 2019 to 2025. This is the first half of this presentation is initially on the foundation of care, so this initiation series. That last line should have been removed because we actually were able to get the long-term care for this in time for the conference. This ended up going through the same MGB team. And so they're actually able to add adolescence as one of the model variables when you're looking at all these regression models. So everything else you've seen from us today did not include adolescence. That was intentional to make it an adult-focused set of outcomes. But then we were able to do the same statistical framework and looking at our adolescent cohort to see if we could tease anything out. For kind of clinical purposes, we ended up bucketing people. You could treat age as a continuous variable, like does age affect outcomes? But if we wanted to be able to make strong statements about individuals under the age of 18, we wanted to keep them as a distinct category. So these models have adolescent under 18, 18 to 60, sorry, that should say 64, and then 65 and above. So this is, again, the same set of adults, same set of individuals, slightly higher number from what you've been looking at to date. And I'll just highlight that now this goes down to age 14 as the range, unlike the others you've seen. This is what we saw from a baseline side of things. So our adolescents, there's 17 of them total in this case series. We saw that on average the age was 16 years old as they started care here. I'll note we did end up treating a 13 and 11-month-year-old. So they turned 14 during the foundation. And we considered that to be acceptable. Everybody else was an average of 16. We skewed slightly more in this category to female than we did in our adult cohorts and our senior cohorts. As a baseline depression score, that is significant between groups. They were more depressed on average, not a huge surprise. They had about the same level of treatment resistance. In this case, treatment resistance is 2 medication trials in the last 5 calendar years. We're using the kind of definition that was thrown out there for Spravato by the FDA. Our adolescents had slightly fewer rounds of prior TMS compared to the senior group, about the same as the adult group, and none of our adolescents had gone through ECT, unlike our adults and very much unlike our seniors. One notable difference in the groups is that the adolescents were all MDD. We did not have a bipolar adolescent in this cohort. The comorbid mental health issues of these individuals, again, these are self-reported at baseline and then cross-verified by the psychiatrist. Anxiety at 76%, so 3 out of 4. Fewer incident rate of PTSD as compared to adults, although I'll note that did not achieve statistical significance. So even though the number's lower, at a statistical level, it was equivalent between cohorts. About a quarter of the folks had OCD and substance use disorder. And of those, even though the numbers are different, none of those were statistically different between the various age groups. Meds did show one interesting trend. So in the lighter blue is the adolescents that we were treating. In the darker blue was the total cohort. We did see that our adolescents, I would say thankfully, were on about half as many benzos on average, and that one did achieve statistical significance. The rest of these, despite being different numbers, didn't reach that statistical threshold of a group difference before they started care. So basically, functionally the same amount of antidepressants, stimulants, antipsychotics, mood stabilizers, et cetera. So what do we see? I'll go through these 2 one by one. So on the left, you're looking at just the raw scores, so not doing any fancy modeling. Blue is the adolescent. You'll notice very wide error bars there, like the size of that's pretty wide. That's because there were so few of them, and so we really aren't able to give a narrow average to that, given that there weren't that many individuals. And that there's, kind of squint your eyes, perhaps some slight trajectory differences, where for adults you see this just rapid drop that it goes flat. Adolescents, at least at the very raw data level, look like they're more of a gradual down and to the right, without the kind of huge burst right down at the beginning of treatment. When it came to the linear mixed effects model in terms of kind of predicting differences based on these covariables and kind of what you need to control for as you think about all the different reasons people might be doing different in their outcomes over time, we were able to see these groups slightly pan out. Seniors was really the one that is perhaps not a surprise, but from the bottom up. So on the right, the orange line is our adults, the vast majority of who we treated. The lighter blue line is the adolescents, and the seniors is the green line. So take that to say that basically individuals greater than 65 have a meaningful improvement. It still works in those individuals, but it did not work as impressively as it did for adults. We somehow lost in putting up the slides the values. The takeaway of this was that for adolescents as compared to adults, while those look like they start to diverge, we did not see statistical significance in the divergence. So even though it looks like they're doing slightly different, at kind of a raw aggregate level, you're seeing a comparable treatment response in adolescents as compared to adults. That might change as we treat more adolescents. The prior RCTs showed that the kind of clinical number you can walk away with is something like 55 to 60% of adolescents were responding to IV ketamine in those trials, as compared to what is generally said to be about 70% effectiveness for IV ketamine as a series for adults. So roughly a 10% difference on the trial side of things with very small numbers. We didn't see that pan out, although again, if we treat more, you might start to see what wasn't a significant difference pan out a little bit. I will say that even if they are different, they are both still very, very significant responders to treatment. So even if it's not as good as adults, it's still pretty freaking impressive for somebody who's had that challenge to be able to do that much better that quickly. How did these adolescents then do over time? So as a reminder for our practice, what we will do is symptom-driven care as it comes to the maintenance phase. We basically say if this orange bar, the orange color is your PHQ-9, your mood, starts bad, you get your 4 treatments, those 4 dashed lines in the foundation, you do better. Again, we kind of wait until we start to hear about or see symptom worsening before we trigger a booster visit, with the goal of having that booster visit within a calendar week of the symptom onset. That seems to allow us to keep it to 1 infusion if it happens within a week of symptom return. If we wait longer than a week of symptoms returning, we tend to need to do more than 1 visit to get somebody back to their new established baseline. So the adolescents that we treated, 15 of them out of the 17 elected to continue care. These were the 2 individuals that did not continue, basically didn't have a threshold response that was deemed to be worth continuing. Their psychiatrist and the patient didn't feel that it was successful enough for them to keep going forward. We saw that in terms of time between visits for the remaining individuals, that there's a very wide range. Some of the adolescents were coming back around 14 days, and some went almost 9 months before their first booster visit. So they were saying that their symptoms were actually okay and not in need of treatment, with continuous follow-up on our part for a 9-month window. This is one of those situations, because of small numbers, the mean, the average, was around 30 days, but the median was closer to 76 days. We see that kind of split given the fact that it's a relatively small sample size. But there is basically a decent chance of them following what we see for our adult patients as well. We've been doing this for a bit, and so in terms of the total number of infusions over time, these adolescents have ranged from a single infusion post-foundation. Again, you're holding aside the 2 that didn't go into long-term care, but of those in long-term care, 1 of those individuals has come back once, and we've had 1 adolescent who's now had 81 treatments with us over the course of our monitoring them. The mean in this case is 18, so on average it's about 18, but because of that huge variation, median's a lot lower at 8. So most of them don't come back that often, or haven't had that many treatments, with some of them having a marked number of treatments over time. And in terms of the kind of lifetime or life years of care that we've been given, again, it's a pretty big swing. The shortest adolescent who was in care for the duration of this analysis was 38 days. That adolescent is still in care. So basically they started relatively late into the cohort that we took a snapshot of, and we're still managing them and have been for the last 38 days. And then we have 1 individual who's coming on 3 years now with us. They're no longer an adolescent. They are now an adult and are receiving the same care as they would have otherwise. Again, you can see that difference between the mean and the median, which is a significant amount of care over time, roughly a year on average that these folks have been with us. Giving this a little bit more, again, this is a case series, so these are individuals. There's few enough of them that we can actually get pretty good stories about them. So the first person I'll talk about is this 15-year-old individual, was 15 when they initiated care. They'd had this formal diagnosis of major depressive disorder, general anxiety disorder, and a deeply heavy cannabis use. That was a substance use disorder in this case. They'd had 5 prior medication trials. They'd gone through multiple therapy modalities, and the kind of off-the-cuff comment from their parent was that they were bouncing between IOPs, residential centers, and inpatient units, were frankly suicidal. Social life is 0, not going to school. These are the kind of qualitative things that they were saying. And on the right, you can see their PHQ score from the first couple of visits. They went from a 16 when they met us, and they went right down to a 6 in those first 2 weeks, with a really noticeable change there. That person continued in care. And because of the degree of improvements they had, we saw them back for their first visit 2 weeks after their last of the initiation series. We saw them again 2 weeks after that. That's what each orange line is here. We were able to stretch that to 3 weeks. We were able to stretch that to 4 weeks. That individual has now gone roughly, about 4.5 months now, where they didn't need treatment since then. And they're still checking in with us. We're still getting these scores, but they've been able to stay in what would be technically remission off that PHQ score without needing additional care. So this was kind of a slam dunk success case. The individuals back in school, they're not super thrilled with that, but they are much better able to do that than they were. In rather typical teenager sense, we asked them to use their words to describe how they were feeling, and they said it helps with everything, and didn't really elaborate. But given the kind of circle we have on them, given we talk to their parents, talk to their adolescent psychiatrists, it is just really clear how big of a difference this has made for somebody who, again, was going back and forth to residential, inpatients, and really just not able to function, and is now living a relatively normal adolescent life. The second one I wanted to highlight here, this was a 16-year-old female. Again, when we started care, they had that treatment-resistant label. The first person did 2, the psychiatrist didn't use the term. General anxiety disorder and a specific label for impulse control disorder. They'd had 7 prior rounds of medication by the age of 16, and they had specifically called out the different modalities of therapies that they'd all been through, including family therapy in this case. Commentary from the child was that they were just sad all the time, no will to keep going, little motivation, trouble focusing in school. They had a even more impressive degree of change. They started worse on their PHQ-9 at a 24, 25 before the treatment. They bopped all the way down to 4 after those initial visits. This person's care has been less linear. So this is our second most treated adolescent that you just saw. They've done 82 infusions over the time. I should know that number. What you can see from this graph is when you start seeing these orange lines really close together, they're getting new series. We weren't able to maintain the improvements, or for whatever reason, they kind of stretched too long between visits. We had to do a new series of 2 or a new series of 4 to recapture those benefits, bring them back down. As you saw a little bit in Mike's data, our adolescents also are not great about taking PHQ-9s between visits. They're taking them in the office when we put an iPad in front of them and say, please do this now. And so part of what you're seeing is these high numbers are the day of treatment sessions. It's the worst they're doing when we record how it is. And then they, thankfully, after the infusions, tend to do them the week later. I think particularly important to highlight for this is in March of last year, the family and the patient and the provider decided to try giving ketamine a pause because they'd been getting so many treatments. It was a risk-benefit conversation about exactly that. They were doing very well at the time in remission when they decided to take this pause. And unfortunately, that pause did not work out well. They ended up, a couple months later, coming back. PHQ was all the way back up to a 27 out of 27. They were pretty suicidal again. And, as we've seen with adults, a repeat infusion of 4, a series of 4 in 2 weeks, got them better again. And they're not perfect. They still clearly have symptoms, but they're not struggling to make it through a day. So takeaways here from our case series, and in conjunction with what's previously been published in a more academic setting, in a more kind of controlled trial way, IV ketamine really does look like it can be viable for these adolescents. We can kind of now show that with some real-world data. This is specific to MDD, so I don't want to extend this to be as broad as adolescents with bipolar disorder. We did not have the ability to study that for our cohort. And then again, from a statistical standpoint, we didn't see meaningful differences in treatment effects as compared to our adult cohort, which should be actually rather reassuring, particularly because when you start treating adolescents, they become adults. And so it's nice to know that starting them in care earlier when they're less functional can still go really well for them over time. So with that, thank you. Any questions? Jeff, while we're waiting.
Did you have any moments where you were worried about kind of conversion or introduction of altered states, or them seeking out from friends at school, or telling kids at school about it, or any of that kind of stuff that you kind of worry about sometimes? It's hard to know where the risk benefit is on that.
This group and the poster you saw on us treating postpartum women, these were enormous internal conversations before we were willing to do this as a practice. And a lot of that was very much the kind of focus of it. Like, hey, there is some data here, not nearly as robust. Is this really something we want to go into? The adolescents we treat, generally speaking, are much sicker than the adults we treat. And so these really were situations where we were being approached by parents My child is suicidal. I do not know what to do. And I think those are very real concerns, particularly the diversion and misuse side of things. We have not seen that in the individuals we've treated. But our stance at the time was that given that they've had the kitchen sink thrown at them and so many meds thrown at them and so many attempts to try to get them to function, that we had to be willing to give this a shot and make sure we recorded what we did to verify we weren't just doing this for doing its sake, but really being honest that it was making a difference. And that's kind of where we landed on the risk benefit. There are absolutely risks, and we're quite conscious of that, similar to treating our substance use disorder patients. Real risks of that, and real conversations we have with the patients and their providers about the risk benefit there. But the weight of it landed on an informed conversation with the family and the adolescent about the potentials, pros and cons, and having a joint decision on that front. And in this case, the pediatric psychiatrist is also always weighing in on that informed decision.
Yeah, I have to say, hats off. It's a powerful model and one, it's a lot of work.
Yeah.
And there's always risks and benefits, but you've created a kind of a rubric doing that properly and
I appreciate that.
while protecting you as a team and protecting the patient.
Oh shoot, I didn't mention that, but thank you. This is a separate informed consent. This is not our normal informed consent. We have a different one that we use, and both the parents sign it and the adolescents sign it. A lot of that protective stuff was because of that framework there too.
I have a couple questions here. So what do we actually know about ketamine's impact on the developing brain?
So, a couple ways to answer this. Put on my old emergency medicine hat, I don't blink about using ketamine for pediatric sedation. It's a great tool in the ER for adolescents. You can use it as young as, I think, 3 months, if I remember the FDA indication correctly. Like, we know that for 50 years, you can give doses that are 200-300 times what we give, and that it's okay. Those are single dose exposures. Those are not repeat doses. The person we've given 82 infusions to does make me aware that that is not something that has a great deal of data behind it. But we also know that there are real health consequences and developmental brain consequences to being chronically depressed. And so again, it's that same risk-benefit conversation. We don't know what the repeated dose risk profile might be for you. We do know that remaining suicidal has a real risk to your mortality, as well as your potential consequences from it. And so we wanted to go into this with eyes open.
No, I think you did a great job of kind of laying that framework of the kind of patients that you're seeing with this. I also treat a lot of adolescents, and it's very similar. They're more treatment resistant than the adult patients. They've already been hospitalized, they're had attempts, they've done some residential, they're very, very, very ill. And they sometimes do amazing, like he said, so. But yes, I think we definitely need more data in that space. What happened to the cannabis use for a patient in case 1? I don't know if you know. But
I'm sorry, repeat the question?
what happened to the cannabis use for a patient in case 1?
Oh, I'd have to review the clinical notes a little bit more carefully. When I scanned it, there were comments there about it being less of an impact on his life. He was using a lot when we first met. I was not the treating physician for that one. I was kind of directing the program. I don't know if it completely resolved. I do know that at least some of the commentary for visit notes over time was about using less and the family being happy with that.
PHQ-9 is not approved in adolescents. Do you think it changes the numbers you presented and the outcomes?
It's a similar framework. It's the tool we have, and so it's the one we use. In our case, it also allows us to do the apples to apples of adults to adolescents.
Right.
And so kind of doing the best we have with an imperfect tool.
Are you using the same dosing structure?
Yes, actually. So once a child, adolescent, starts care with us, the clinical care they receive is identical to the care that the adults receive. Same doses, same rescue meds, same everything. The only thing that differs is the chaperone home from a clinical perspective.
Do you provide any kind of integration or preparation for the right mindset of ketamine, given their age and insight, and what does that look like?
We do the same for them as we do for the adults. I can go longer on that one for people who haven't heard it already, but probably maybe afterwards we'll talk. Question, Mike.
Yeah, I was going to ask a question they make statement. I think it's important for you treating adolescents to just keep in mind that 30% of TRD is usually from bipolar disorder. So when I see your second patient there with like very severe depression and very rapid responses, it's
Yeah.
almost like
Well, I think the things that you were bringing up is the exact reason why an adolescent psychiatrist continues to be the primary psychiatrist for these individuals. So again, we don't assume care, we do this, but we make sure that they are continuing in care with the individual who can more appropriately continue to assess this over time. And yeah, some of our patients will, and you saw them on mood stabilizers, and they will continue to have meds adjusted over time per the prescribing provider. I am a little bit less worried about personally, around the schizophrenia psychosis side of things, just because the anesthesia data on ketamine hasn't shown incident rate increases of that. Again, why we would use it in the ER context a lot, because we're not worried about that. But fully agree, that's not the same thing. Incredibly high single doses is not the same thing as repeat doses. And so it is something we would want to have teased out over time. Cool, thank you all.